How did I become a skull-based surgeon? I think if I talk meningiomas and acoustic pneumomas, I think you guys will be bored. Believe me, if I talk about intricacies of acoustic pneuma surgery, you will say, what the hell, man, 9:30, you're talking about P1 perforator and PCOM. Let me talk about my journey. I think that will be, useful for some. Of course, I know she's staring at me. I will talk about some pituitary or something like that. But let me, for the youngsters, a lot of youngsters here, Anvita always, attends my live.
Number one fan, Abu Dhabi.
Yeah. Because I call her, Anvita, are you here? And then she says, yes, sir, I'm there. So let me tell the youngsters how I start my journey of healing skull base. So first of all, you should understand that training. This is the most important part of a person's development. This is the first thing you should understand. Many people after their MS, what they think is that they get that inspiration from their tutors. Maybe I thought X was very good, Karnathan sir was very good, but believe me, it's not enough. It's absolutely not enough. And if you start a shop, if you start your training program, or if you start your, practice after MS, believe me, you will be nowhere. So this is the first point. If you have friends, and if you're old, tell them. Never start practice after MS. This is the first thing I didn't do. Now, the second important thing is that you should know where is your weakest point. So a coach, for example, if I play badminton, I know my backhand is weak. My coach will say my backhand is weak. My forehand smash is good. So I will try to avoid my backhand and I'll go around short and hit it. So then in surgery, do you know exactly which cell is causing a problem? If you have a frontal bular cell, have you got a problem? Or if you have a type 3 cell, you have a problem. So unless you have recognized your negatives, you cannot become a good surgeon. This is my say. Most of the surgeons in the world, believe me, I've seen this world. I've traveled. There is no country in this planet I have not set my foot on. And I can exactly tell who is a good surgeon because of my travel. So I'm telling you, most of the surgeons overestimate themselves. This is the biggest problem of a surgeon, because they think that they have done it properly. Actually, no. You have so much of scope of improvement. Point number 2, recognize your negatives. Point number 3 is always, maybe I've seen in India, so if I'm in Madras Medical College, I was a Madras Medical College student, I was a gold medalist in ENT, and I thought I was big. But when I saw the south of India, I became a little smaller, because I saw, colleges like for example, NIMAPS and things like that. So I thought, I have to improve better. When I saw KEM Hospital, I saw MAMC, AIMS Delhi, I became still smaller. But I was comparing myself with people in India. And I felt that I was at one point good, but when I went outside India, when I saw the Americans, when I saw the Italians, when I saw the Japanese, when I saw the Chinese, I felt I'm nowhere. So my third take-home point is that if you are in a particular place, don't ever bother about your next door person. This is universally applicable. You just have to raise your own standard. You are not bothered about anybody else in the society, because you set standards by world. Today when I stand here, I know what is going on in Italy. I know what is Paul Costanovo is doing there. I know what is the latest invention of Paul Costanovo, at least in rhinology. At least in skull-based surgery, I know what Pittsburgh is right now doing. If they do a pontine glyma, I know tomorrow what is being done. I'm so inquisitive to know, even at this age, what is going on around the globe. What are the Japanese doing? What is the latest invention with AI, which is being done in Japan, in China, in Italy. So the moment you start coming, maybe you're in Abu Dhabi, going out of Abu Dhabi, your mindset going out of Abu Dhabi, this is the first sign of progress. So you just can't stay in Abu Dhabi, say that I am the best in Abu Dhabi. You are nothing. When you think about it, you're nothing. When you compare to one Chinese who is doing 11 dissections a day, and he can just take out hair cells of the cochlea, my dear friend, by dissections. You will be showing the facial now. This is the vertical portion, horizontal. He will be showing you the fibrils inside the internal acoustic matter. This is the kind of the running they are doing. So, point number 4, point number 3 or 4, whatever. You have to compare yourself with the world standards. Number 5. You might think that you're good in a particular field. If you're good in a particular field, never project yourself as a general ENT surgeon. That is, if Dr. John is operating on head and neck, he's operating on pituitary tumors, he's operating on CNAs, he's operating on so many, and you want to publish yourself as a global leader, okay? Not in Abu Dhabi. Abu Dhabi, everybody knows, it's a small community. Dubai, everybody knows Syed is the best, anything like that. But if you want to publish yourself as a global leader, you can't go and say, I am doing this, thyroid, this, that. Nobody bothers. So what you have to do is hyper focus on a particular area. For example, in Chicago, in a toilet, people talk about JNA and Janakiram is there. Believe me. In Brazil, if somebody talks in some park to ENT surgeons about JNA, Janakiram is there. This is what I have left behind as a legacy. When I die, my name cannot be erased from JNA. I'm not trying to brag, but I planned it at 25. And that's why I'm like this here. Okay, so JNA means, previously in congresses, they used to just say, call Janakiram. Kevin is saying JNA, call it. So this is the point number 5. Youngsters, don't defocus. Even if you defocus, project yourself under a hyper-focused area. If you have implant, if you say I am an implant surgeon, who cares, man? Everybody, every other gully, 11 gully, 12 gully, 13 gully is doing implants. What's there in an implant? In an implant, if you say I do the Mondini in that, I am doing some type 2 malformation and I am the specialist, they call you. Believe me, this is the present situation. So this is point number 5. Hyper focus when you project. Never defocus when you project. Point number 6. Expand your horizons. For example, how did I become a skull-based surgeon? I was a rhinologist. So easiest way to skull-based surgery. I'm telling you the path. Easiest way to skull-based surgery. Easiest way to any field for that matter is to do one prelims. For example, you have a subject before it. For example, I want to do an acoustic. Unless I do a proper facial or decompression, I cannot do an acoustic. Please, this is basics. Unless I do a transaortic approach, I cannot do a petroclival meningioma. Please, these are all basics. So you have to do the prelims. So for that, I should do a good masterectomy. And for that, I should do temple bone. So I started like this. I knew I wanted to become a skull-based surgeon. First is rhinology. In FES, close your eyes. Put a plaster in your eyes. You should be able to open the frontal sinus. Any cell you give, type 1, type 2, type 3, frontal bular, suprabular. You should not, keep the building block technique and put a software and do it. So I'm not trying to criticize anybody. PJ Ormond is my very close friend, but you cannot do it now like that. You should close your eyes. Okay, this is a type 3. I go here. This is the common drainage pathway. Open the frontal. That is the kind of authority you should have in frontal. Then you go for draft 3s. You should have done at least 10 draft 3s before you venture on today's case. For example, ACFR. We did an ACFR today. And before you do an ACFR, at least 10 drafts. And draft, you should close your eyes and do. This is the first olfactory neuron. This is where I'm drilling. This is the frontal T. I'm going to reduce the frontal T. Closed eyes. Then, many people say I do the pituitary surgery. as if they are very great people. I have seen Pakistan. I'll tell you my history, then you will know. I am a pituitary surgeon. I don't care if you're a pituitary surgeon. Show me the Pernix-Keys triangle. Show me the boundaries of the Pernix-Keys triangle in the pituitary. Then I will talk to you. First of all, you should know what is the Pernix-Keys triangle. I have met John Pernix-Keys. You see the difference. So, what I mean to say is, you have to know A to Z about that subject. So, number one, start basics. Then what I did, I went to the frontal, I advanced to the frontal, went to the draft 3, then I got a lot of extracranial tumors. That's when I did a lot of research on JNAs. So I thought I should be the author. That's why we published 18 papers on JNAs. We were the first to do many JNAs in the world. Leave alone the number of JNAs. India is a hub of JNA. What I mean to say is extradural tumors, then go for intradural tumors, and then go for perforators, aneurysms, and things like that. So, point number 6, start basics, go ahead. The 7th is the most important. I love 7 number, and that's the most important thing. How many surgeons here in this audience? I will tell you how many surgeons in this audience have a coach. How many surgeons in this audience have a coach? I am 100% sure 100% of you will not have a coach. I know the training. You know why? Because you think that you're doing the best. I'm not trying to insult anybody here. Have you seen Pete Sampras playing a game without a coach? Have you seen Lee Chong Wei playing a game, Lin Dan playing a game without a coach? Have you seen Saina Nehwal playing a game without a coach? Have you seen PV Sindhu playing, even when she is top-notch, world number 1, playing without a coach? Why do surgeons don't have a coach? Have you ever thought of it? If a game needs a coach, if a scuba diving needs a coach, if a barber, I've seen barbers, they say, is it right? Can I cut like this with the stylist? He has got a coach. Why can't we, playing with human body, have a coach? So, I am sure that you would have seen this study by Boston University, where what happened was, the doctors, the cardiothoracic, I think you would have seen it, I am sure you would have seen this, very famous. Yeah. The cardiothoracic surgeons, what they did was, they started operating at their 10th year or 12th year or 13th year, and they had a graph of their results. And then what they did was, they employed a coach. They employed a coach just to come and stand, just to correct them. And they saw the results. It was a tremendous leap in the results. Even though these CT surgeons were 10, 12, 15 years down the line. That means what you think you're doing right may not always be right. So you have to change every day. Your techniques might become obsolete. So this is my 7th most important point for all of you who want to excel in the field of surgery, because you are operating on live human beings. So you can ask me, how do you coach yourself? I'm already a coach, but how do I coach myself? Yes, I do coach myself. You know how? Every other day, I send some of my videos to my mentors. Like Amin Kassam, I send my videos. I get my feedback. I ask them, have I dissected this perforator properly? I used to do that. Now maybe 3 months once, 6 months once, occasionally when there's a difficult case, I send it. And then I get that feedback. No, this is wrong. The forceps should have been like this. The forceps should have, when I do a nasopharyngectomy, how should your scissors be towards the carotid? Can any of you answer? You can't. I'm telling you, because you've not been trained like that. So I was trained like that. Because your scissors towards the foramen lazinum should be downwards, medially direct. This level of coaching I have. Of course, you don't see the master is not going to whip you and say, no, you have to catch hold of these points from him. When he's doing it, silently observe him. wow, this is how he's holding it, this is how I will hold it. So this is the kind of observational skill you have to develop if you want to become a fantastic surgeon, believe me. And I see that many of the youngsters, they are scared to even send their videos or even project their surgical skills. And this is even my son. I tell him, what the hell? But he says he keeps sending it to me, and he asks me, Dad, is it right? I scold him left, right, center, up, down. Man, this is wrong. This is wrong. This is wrong. And then he gets a little mood out. Then 3 days later, he gets up and says, again, you're wrong. This step is wrong. Unsned, your backbite is wrong. The angulation where you're pointed is wrong. Where you're introduced. Boss, surgery is an art. It's a skill. It's not only a skill, it's an art and a skill. It's a science. It's pure science. And unless you learn the art the right way, you cannot create a jerk reaction in this world. Believe me. Earning, boss, any donkey will learn. Please. Please. I'm telling you. My minute earning is 25 lakhs, boss. Per minute earning is 25 lakhs. Now, people call me to, sorry, I should not tell this, I'm not talking out of my head. Jordanians called me. I said, what is your, previously 20 years I have gone to teach neurosurgeons. Now, if they call me, I ask for first class. And then I ask, what is your honorarium? I'm called now to Italy. I said $20,000 per hour is my honorarium. Can you afford me? I asked the same question. Believe me, this is what I asked them. Then they changed my ticket to first class and they reduced my honorarium to $10,000 a day. But I don't want to go there just like that. I'm not a... See, if Shah Rukh Khan can charge 60 crores to come and show his face, why should I? I am better than him in any way. So now we should also start marketing ourselves. So try to post your videos. Anvita, post your videos. Ask your doubts. If you're having your video for yourself, how will the other person know? You will think that you're good. You will think that you're doing the right surgery. It might actually be wrong. Please understand one important thing. Quantity never leads to quality. Doing 100 stapedectomies doesn't mean that you're doing it well. Doing one stapes properly means you're doing fantastic. And it should have your thumbprint. All. Okay, now I think it's too much of blah blah. Let us go on to some talk, which is going to be on skull-based surgery.
नीचे
Boss, okay, I'm not going to talk too much. Let me just talk 1 or 2 videos and come on. I think that will be fine. Okay, right. You know that I've been operating. This is the duroplast. So we generally use a lot of alloplastic materials for reconstruction. Of course, we also use medical vascularized flaps. This is actually the DuraGen. After the duroplast, I'm using the DuraGen. DuraGen is to replace not the dura, but the arachnoid. This is the facial adder onlay. We do what's called the bulldozing technique. Of course, I've shown it in many live surgeries which I've been demonstrating. And then what you do is you just do so always do the bulldozer whenever that's the Janus flap. This is called the Janus flap. So bilateral, one is a big hadar and one is a small hadar. So that's the Janus flap. And this is the end of the surgery. So I'm just going to show you one case of a very interesting case. This case is there in my book. You can read my book, and this is an acromegaly.
Acromegaly is a very nice tumor, basically because if you don't remove it completely, you will not get a good growth hormone and IGF-1 level. So I make sure that I chase the tumor micromillimeter. So I am very, very particular that any secreting tumor, like Cushing's, I'm very fond of Cushing's or acromegaly. And I see that I remove the tumor completely, or else to revise these tumors are more difficult than doing it first time. So you see here that I'm just taking off the cellar floor, and this is the carotid. You see, I always expose the carotid. That's the carotid here. I use my Doppler. I never operate on skull-based surgery without Dopplers. And you can see here that I'm using the Kassam scissors. So you see, I'm using the Rosen's elevator. What is the direction of the Rosen's? How we slide the Rosen's? Everything is measured, my dear friend. So it's not that, so see where my suction is there and where my Rosen's is there. These are all points, micro points, which we can't discuss in detail. So now then we do what is called the two suction technique. We start with a 6 o'clock position, and then what we do is, you can see here that the tumor, acromegaly tumor, is a little yellowish in color. You can see that's the yellowish color of the tumor. And the problem in being yellow is that the normal gland is also yellow. That's the problem. This is the inferior epiphyseal artery here. You can see that's the carotid artery. This is the cavernous carotid. But the tumor is sitting here in front of the carotid. That's the anterior compartment of the cavernous sinus. And what we are doing now is to remove that tumor from the. So that is the triangle called the oculomotor triangle. So above the carotid, you have that's the oculomotor triangle. Clearly seen. That's the bluish diaphragma, and that's the normal gland, which is yellowish. See both sides, carotid, inferior epiphyseal artery, stalk in the center. See how this is the classical textbook description. So, in fact, one person who really appreciated me was Gently. Gently, have you heard of Gently? He's done only 7,000 pituitaries he's done. And I did a pituitary in front of him. He said, he's from Canada. He said, one of the best pituitary surgeons I've seen. Gently wrote it for me because I did it in KM hospital. I operated there. Okay, that's a prolactinoma, but anyway, I'm just going to go further. Just see this. These are all tumors which we do day to day. In Royal Pearl, we do at least 4 skull-based cases, proper skull-based cases like this, intradural, every week. And neurosurgeons, they stand, they see, and they see us operate. It's not that they operate. I mean, it's not the person who operates. I mean, it's not the degree which operates. It's the training which makes you operate. So here we are. That's the dura being cut in the plenum. You have dissected the optic canals, and you're removing the tumor from the plenum. That's actually the suprasellar component. So you cannot pull. I told you that's actually the through biting forceps. And you can see here that this is the internal debulking. It's called internal debulking with extraretinal dissection. See, now that's the optic nerve here. That's the intradural optic nerve, and that's the carotid artery. So you see how I'm using my scissors. Again, the angulation of the scissors, that's a perforator. So you can see how the scissors are being used. So, and then you can see that this is the internal debulking being done. And once we remove that, you can see that you never pull at a tumor. Very, very, very important, my dear friends. So you have to dissect. That's carotid artery here. This is the internal carotid artery. It was engulfing the carotid and the optics, and now you can see that this is again being dissected out of the optics and the carotids. Always remember that the normal pituitary gland will push downwards. In a case of meningioma, it will be pushed downwards. In a craniopharyngioma, it will be pushed downwards. The normal gland is pushed upwards in a case of pituitary macroadenoma. It's pushed anteriorly in a case of cardomas. So these are all diagnostic points for you to make a diagnosis preoperatively. So you can see here that we are rotating. It's called the roll-on maneuver. So all these I learned from Ohio State, Professor Daniel Crevello. He's a fantastic neurosurgeon. So you can see here that this is actually the tumor being removed. It's a classical meningioma. We've done more than around 52 cases or so of such cases across the world. So endoscopy. So you can see here that this is the meningioma being removed. So, and you can see that's the anterior cerebral separation. This is the A1, and that's the ACOM. You have 4 ACOM perforators. So you can see that's the stalk. This is the pituitary stalk here, and you can see the A1. How it's see the ACOM. This is the ACOM, and that's the ACOM perforator. You can see how nicely. This is the most delicate part of the circle of Willis. And if you do something bad in this, it will go into spasm and the patient will have an infarct. So these are all very, very important points. See how we are rolling down the anterior cerebrals, the tumor of the anterior cerebral. See that ACOM being separated. So this is just to show you the kind of handling we do on these tumors. And you see here, this is a very delicate part of the surgery is to separate it from the, and you see this is the final result. You see how that's the optic chiasm here. That's the optic tract, that's the optic chiasm. See how this is being rolled, it's called the rolling down maneuver from the ACOM. So you can see here so that's the tumor which is slowly being removed. I'll show you the I'm not able to forward the video, that's the problem. That's a pituitary stalk. That's a perforator directly coming from the carotid artery. So you see that that's a Kasam bipolar being used. So one thing important is you should have instruments, proper instrumentation, or else you will land up in problems. That's why I made sure in Medcare we have the right instruments to operate, or else I will not do all these cases. So here we are. So we have now removed, that's the perforator from the carotid, direct perforator from the carotid. And then we remove this tumor with a rolling up maneuver. It's called the rolling up maneuver. That's the arachnoid being separated, and you can see here. So basically, people ask me, are you an ENT surgeon or a neurosurgeon? I always say, I still don't know. I'm neither. I'm a skull-based surgeon. So this is the answer I always give. And I'm not going to bore you too much because I know that put the lights on, please. We will not have too much of lecture and then you will get bored about me coming here. So, just want to say thank you for calling me. These are all some of the cases. So, you might ask me, how are you able to operate in Dubai? Dubai is like, a very difficult place. People have problems, they will sue you. Believe me, I have operated in countries which are more difficult than Dubai. We have operated in America, I have operated in America in neurosurgery. I operated in Japan, Taiwan, Korea. These are all not like India. They are very advanced countries. And having done that there with neurosurgery, I don't feel any problem operating in Dubai. Everybody is the same, right? The human being is the same anatomy. So when Professor Syed says, but only problem is, Professor Syed has also done his MD psychiatry. I have not done that. So most of the patients are a little psychotic when they come in Dubai. Of course, that is one extra problem which I am facing. But however, with respect to the surgery and complications, we did an acoustic, most of the tough cases have been already done in Dubai. And I'm not at all scared to do it, provided I feel that the right equipments are there, the right team is there. So I need a neurosurgeon, I need a good partner for me to hold the scope and of course take care of the post-operative patient. So I'm not going to bore you again. Thank you very much, Dr. John. I'm open to questions. And thank you, Abu Dhabi, for having invited me here. Of course, you might think that I've abruptly ended this talk. Believe me, if I go on, it will go on for hours. I'm a very passionate speaker. And sometimes I start in the morning and go till next morning. When I see people falling down, I just pull them and say, you have to listen. So I'm a dangerous guy. I exceed my time. So I consciously thought, let me stop it before people just, start seeing their cell phones. Thank you very much.